without further ado from me, I'm going to introduce our panel. See if I can. Oh, there's Dr. Mark Karakortis. Mark, good to see you again. Mark is a former board member of the NBIA board. He also has a son with NBIA. He is a board certified oral and maxillofacial surgeon. He lives in the Republic of Austin, as I do. And so glad to see you, Mark.
Thanks, Mary.
Also, we have with us Dr. Jerome McMahon. Hope I'm saying that right.
Yes.
Nice to see you. He is a dentist and director of the University of Cincinnati, my alma mater, Medical Center and Medical Center's Dental Center. So, Dr. McMahon, thank you for joining us. We're happy to have you. And then we also have his colleague, Dr. Nicole White, who is a staff dentist at the center. So I'm going to get started because I have a question, and I'm going to pick on Mark because I know him. Mark, can you give us some tips on how you dealt with dental issues with your son, besides taking care of him yourself, of course? But you know, I always think of dental care as something that you don't think about until your teeth fall out, and then it's too late. So can you know, are there certain things that parents should be doing every day for their children, or, you know, some special things that they need to do, especially with NBIA individuals?
So great question. And as we know, the disease spectrum just affects people in such a different way, from very mild to very severe. But there are some general concepts, I think, that are really important to consider. And I think you hit the nail on the head. Oral health kind of seems to take a back seat with a lot of the other medical issues and problems that we have to deal with on a daily basis. But I think it's really critically important. You know, things to think about, you know, early visits to the dentist, right? 6 months to a year, or as early as you can, to start a relationship with the dentist. That really is key. Prevention, you know, what can you do if we're eating by mouth? We don't have a feeding tube. We can eat foods that are a little bit less susceptible to causing us decay and caries and problems like that. You know, Dr. McMahon and Dr. White can help us with that much more than I can. Brushing teeth, really important, and it's hard. A lot of our kids have severe dystonia, and it's tough to get into the mouth. And hopefully we'll have some questions about that we can delve into. You know, how do I do it? How do other folks do it? And then think conservatively, right? Prevention, conservative management, intervene when there's a compelling reason to intervene. We can create a lot more problems in these kiddos and families by being overly aggressive. For example, going to the operating room and going to sleep. Very natural way to take care of folks with other disabilities, but maybe not the best in our families and our group of kiddos.
I would like the other two to weigh in on this. Dr. McMahon, what do you think, and what do you advise? And do parents need to take the kids every 6 months? Because that's the way I was brought up with this.
Yes, I think that's great advice. Certainly with the younger patients, to establish a relationship, as Mark said, with, in particular, a pediatric dentist, and developing good oral hygiene habits. Prevention is absolutely key. Quite honestly, in most other disabilities, we would quickly jump to the idea of going to the operating room, patient being asleep, and getting things taken care of in that mode. With this situation, that is not what is recommended. So the prevention becomes all the more key. And part of prevention would be practicing good oral hygiene as best as possible. We can talk more about that shortly. In addition to establishing good habits with dental visits, so that there is some monitoring of the oral health. And then also prevention in the sense of watching the diet to prevent decay. With decay being such a difficult entity to treat in this patient population, prevention is paramount. Best thing for prevention, in addition to good oral hygiene, is really the diet and paying attention to what are cariogenic or decay producing foods and drink. So sugar content is super important. It's very common sense to us as dentists, but sometimes it's not all that apparent to individuals that, you know, that Gatorade that you drink, well, there's a lot of sugar in that and it has a very low pH. So it may not be actually a whole lot better off than drinking a Coke. And I think most people would say that a Coke would be obviously a source of sugar and possibly causing decay. But sometimes sugar takes on forms that you're not necessarily aware of. And if you were to be able to keep those out of the diet, you're going to be much, much more able to avoid cavities.
Dr. White, I'd love to hear from you. What do you think?
I would agree. I would say that getting to, a dentist, the recommendation is typically 6 months when those first couple teeth start to come in. The earlier you're going to get to that dentist, the more they can kind of help with the dietary counseling that Dr. McMahon, was talking about. I think also just getting used to, as the parent, getting in there and being the one that's likely going to be helping out with brushing. That dentist can help you know what to look for, what looks more normal, what's something that's a little more concerning. So as a parent, you feel more comfortable kind of doing a little bit of a visual exam yourself. And I think that would contribute to a sense of, calm and finding things when they go awry quicker than later.
We've got a question that's come in from one of our participants who says, my 6-year-old daughter grinds her teeth extremely badly. Her front teeth are down to little nubs now. I feel like her dentist is very dismissive of it. Side note, they are pediatric dentists, not specific to special needs. What should she do?
Do you want me to take that one, or?
Yeah, please jump in if you've got something to advise. Yes.
So, tooth grinding, clenching, pretty common in a lot of the subgroups of the NBIA disorders. Primary teeth tend not to get a lot of attention, right? I mean, most dentists would say, hey, the primary teeth, they're going to go away at some point in time. Let's not lose a whole lot of sleep. But the reality is there can be a lot of discomfort and a lot of pain associated with primary teeth and lead up to abscesses and things along those lines. There's not an easy solution. Botox might be something to consider in this young woman. That would be something that her neurologist, her physician, and possibly an otolaryngologist would get together with and discuss if it's appropriate. That really, short of putting an appliance in her mouth, and, Jerome and Nicole, you guys would have more experience with this than me in the pediatric group, but that doesn't make a whole lot of sense in my mind.
She says that her daughter is got baby teeth still. And is there a way to prevent what's happened to the baby teeth from happening to her adult teeth? Does anybody want to take that one?
So likely the idea of bruxism and preventing that is probably not very much possible. I think you're going to notice some wear. If it's simple clenching, that's one thing. You won't have nearly as much wear. But if you do have actual bruxism and grinding of the teeth, the difficult part with that is, well, in other circumstances, we might make some type of an appliance. That might be a little bit challenging in this patient population, to the point where that may not really be possible, and also could be, even a safety issue as far as an aspiration risk if we were to make some type of an appliance. This is not unique to this patient population in the special needs arena. We run into this very commonly with many other entities, and it's a difficult problem that I don't think necessarily has a solution, at least that I've been aware of.
We have a great question from someone who has a daughter with BPAN. The girl is 14 years old. She sees a dentist at the children's hospital, but she doesn't want to cooperate. We've taken her for many years, but she has high behaviors, so she usually has to be put under to do any real work. Her dentist wants to pull her premolars, but my daughter cannot use an open cup. I'm not sure what that is, but I know you guys will know and can explain it. I'm concerned about dry sockets, and she only can drink from a straw cup. Oh, I get it. As my daughter gets older, I become more concerned with putting her under if I don't absolutely have to. Is this elective, or is it imperative to remove her premolars, i.e. putting her under? How probable is it that she will get dry socket from it? She's nonverbal with a very high pain tolerance, and the idea of an infection is a big concern. So there's a lot there. Who wants to take that one?
Well, I'll take a stab at it to begin with from the oral surgery standpoint. It's unclear to me, and maybe I missed it when you were reading the question, but the reason for removing the teeth, I'm assuming that they're carious or non-restorable. If that's the case and she's in pain, then the teeth need to come out. That's a compelling reason to remove the teeth. I would be very not concerned at all about a dry socket. There are things that the surgeon or the dentist can place into the socket to help mitigate that. As far as drinking with a straw, there should be really no issues with that. Nothing should change as far as what she's able to drink, just removing a couple of bicuspid teeth. And the idea of infection is a big concern, I think I heard you say. I would say that that's a pretty low probability, a low risk in removing bicuspid teeth. And I think the risk of keeping those teeth, if the issue is caries or infection, certainly outweighs the risk of removing them. And lastly, I would echo, and I'm not as familiar with BPAN as I am with others, but I would echo, going to sleep only if there's a compelling reason.
Good. I've got a question for the dentists about toothpaste. Is there a certain toothpaste that you recommend for a child who can't spit or rinse their teeth?
I think any commercial toothpaste that has fluoride in it. So the seal of approval of the American Dental Association indicates that the toothpaste has fluoride in it. Obviously, minimal amounts of toothpaste, so that if there is no ability to spit, that there is not much fluoride that's being swallowed. If the patient has a high caries risk, has a high decay rate, the dentist may consider a higher concentration of fluoride in the toothpaste. Brand name, this is a prescription item at this point. Brand name that's generically out there is Prevident. And there are multiple others, but Prevident is a very common prescription that we write in our special needs patients. I would definitely keep it to a small amount of toothpaste, though. For example, a good way to go about putting the toothpaste on the toothbrush is, it's more of a pea-sized amount, so maybe going across the brush horizontally instead of the whole length of the brush, or even just a slight smear is good. So I don't want to dismiss the idea of oral hygiene by any stretch of the imagination. On the other hand, decay really is a disease of sugar, in my experience. If there is not a significant source of sugar in the diet, yes, we want to have good, clean teeth, practice good oral hygiene. Decay is much more of an issue when there's a significant source of sugar in the diet.
Well, a related question from a parent is, are there toothbrush alternatives that may help with our kids, particularly auto brush? My daughter fights with me to help her in brushing every day and night, getting to all the surfaces of her teeth. So is there some alternative there that y'all could recommend?
I would encourage the use of some type of a mechanical brush along the lines of Sonicare. I have no interest in Sonicare, don't take that the wrong way, but it is a mechanical brush that may help. And I don't think there's really any risk of having any problem with that. Certainly a straight manual toothbrush is perfectly fine as well, but there are multiple different types of mechanical brushes. Again, Sonicare is one brand that I think works very, very well.
And I would echo that. I think the Sonicare really has been very effective when I look at my own personal situation with Drew. The other thing that you touched upon previously, Jerome, was expectorating these toothpastes. Home suctions are pretty common, so that's one way that we could maybe rinse with water and suction the toothpaste out. But I did have a question. What about children's toothpaste? Does that have less fluoride, less of a risk if that's swallowed? Maybe that's something that families could use.
I'm not so sure about I'm not a pediatric dentist. I'm not so sure that there is necessarily a lesser amount of fluoride. I would say that the idea of how to administer the dose, so to speak, by doing just a smear or by going across the brush horizontally instead of the entire length, that would be the way that I would limit the amount of fluoride so that there's not too much of an ingestion, risk of ingestion.
Thank you.
Got a great question here from a parent who wants to know if switching to a Gtube changes oral health needs, and what, if anything, do we need to do differently after the switch?
I'll start. I mean, a Gtube doesn't mitigate the need for oral hygiene. In fact, you could get a little bit lazy and forget about brushing and mechanically cleaning. It's probably just as important, if not more so, in folks with a Gtube. Don't neglect that aspect of it.
Dr. White, do you want to weigh in on that one?
Typically with the transition, can you guys hear me? Yes. Okay. Typically with
I hear
the
you, but it's soft. If you
okay.
can,
Typically with the transition to a Gtube, you're going to see more calculus buildup on the teeth. There's different types with my patients that I've seen of feeding. Some are, there's still some sugary items put in the mouth to kind of give the patient the concept of eating or something pleasurable. Food makes everybody happy. I understand that, but trying to limit that to the sugar-free or less sugary items kind of helps. The saliva is a little bit different, and the calculus buildup is more severe when you do have that Gtube. So if you see that yellow kind of buildup on the teeth more with that transition, I wouldn't be surprised if it needs to be scraped off.
I would concur with the idea that the calculus buildup becomes much more of an issue. And as to Mark's comment that oral hygiene is just as important, if not even more so, to try to prevent the calculus buildup. So just a simple act of eating does dislodge some buildup from the teeth or prevent as much buildup. So when there's not a significant amount of food intake, not chewing of food, you can then end up having a significant amount more of calculus buildup. So oral hygiene is certainly still very important, even in the Gtube patient.
I want to get back to something that we discussed just a minute ago about anesthesia. When One of our questioners says that doctors are indicating a lot of concern. You all are indicating a lot of concern about putting people under. And she says that this isn't something that had been indicated to me previously. What's the reasoning for more caution with NBIA anesthesia?
So there was a great paper put out by the folks in Oregon and worldwide about 4 or 5 years ago. I think it was 2014, 2015, which kind of outlines, pecan in particular, but I think that there's some applications, and I don't recall the name of the article off the top of my head, but the general concern is anesthetic agents can create or exacerbate a dystonic storm, both primarily post-operatively. There's also issues of airway management, so keeping the patient safe and breathing, right? A lot of our kiddos have aspiration difficulties. They tend to clench their teeth, which makes it difficult to intubate. And then you have the anesthesia recovery, which sometimes can be fraught with a lot of complication and difficulty. And so if there's a compelling reason to go to sleep, then we do it. But it's not, it shouldn't be used haphazardly. It can create issues that may be worse than the problem we're trying to take care of.
I have a question here that maybe one of the dentists could answer for us. It's from a parent who has a 19-year-old daughter with BPAN, and it says that she brushes her teeth with support daily, but all her teeth are decaying quickly. The dentist isn't sure why the quick decay. We've tried the higher fluoride toothpaste. Even with minimal spitting, we have also increased to 3-month cleanings. Is there anything else that you would recommend to prevent this quick decay of her teeth?
I can only speak from my experiences in the world of general dentistry over many years. Sources of sugar can sometimes take very unusual forms. So I've had a patient, these are very well-educated healthcare provider types, and cavity every time they come in. I'm very healthy. I don't drink pop. I don't eat candy. I don't do any of those things. I brush my teeth. After almost literally multiple recalls every 6 months, so this is over a period of a few years, finally the light bulb went off, and this individual was putting a Halls on their tongue at nighttime to clear their nasal passages so that they could fall asleep. Well, a Halls is essentially sugar with a drop of menthol in it. And that totally turned the game around. I've had another patient who, similar, almost more so adamant about not having any sugar in their diet. They had a lot of gastric issues. They couldn't have different forms of sugar, certainly couldn't drink a pop, had all kinds of decay, and kept returning with more decay and more decay and more decay. Turns out they were eating Tums because of their gastric issues all the time. And Tums, I actually went to the pharmacy with this individual, picked up the bottle of Tums, and the first ingredient is sucrose. So if there's decay, my experience is that if there's decay, there's a significant source of sugar in the diet. I've seen different individuals who might be going to a workshop, and at the workshop they have access to pop or candy machine, and parents aren't really aware of that, and then come to find out that that is the case, and their daughter, son has been going to workshop, and that's where they're getting all their sugar, but the parents are adamant that they aren't getting any sugar at all, but in fact they are. So again, I would be always examining the diet for a source of sugar if there's a high decay rate.
Good. We have a question from a parent who has a 9-year-old with pecan, form of NBIA. The individual still has many baby teeth. He's nonverbal, has severe dystonia, and no longer takes anything by mouth. He doesn't like toothbrushing, has never spit, and at a recent dental appointment, he gave the suggestion to brush with a tiny amount of toothpaste, big kid toothpaste, and wipe it off. but he doesn't cooperate with us very easily. And I'm seeing that theme in some of these other questions about how difficult this oral care is. Anyway, the question is do you agree with the approach that this dentist recommended about, just using a small amount, wiping it off? And I think, there was some discussion about that. Is that a good way to go? How about you, Dr. White? What do you think?
First off, is my microphone any better? Are we?
It is.
I can hear you.
Yeah.
Okay. Sorry. I would probably say, to go back a little bit, pediatric toothpaste often don't have any fluoride in them. That's kind of why they're usually like a bubblegum flavor, a different flavor. So although they will mechanically clean your the action of brushing will mechanically remove some of the things from the surface of your teeth, that protective layer of fluoride isn't exactly what's being put on. So to kind of go in conjunction with this, to mechanically remove some of the buildup on the teeth is not a bad idea. That's really going to help the gums. But in terms of fluoride strengthening the surface of the tooth to prevent cavities, you're kind of fighting two different battles. One is a gingivitis gum kind of battle, and the other is more of a decay rate kind of battle. So, if you truly can't spit and if all you can do is wipe the surface of the mouth, I think that has a benefit. But you're going to have to kind of see if cavities are the problem, the wiping isn't really going to solve that issue.
Yeah, it seems to me that there's a lot of concern about people who can't spit. And so it sounds like your option pretty much is to just wipe the tooth. Maybe, I think suctioning was mentioned earlier. Is that necessary?
This severe dystonia is this oromandibular dystonia, very common in pecan, as most of us know. It's a difficult situation because you can't get to the tongue side of the teeth to clean. So you're basically just doing half the job at best. The issue in my mind is there something we can do to relieve some of this dystonia? Can we do this with medicines? Can we do this with injections, Botox, and so that the patient is able to open their mouth where we can get in there to clean things? So that'll also give them some relief. The other question that I think, and I don't know if anybody's asked this or not, but in this young person in particular, has the dystonia gotten worse? What I've noticed over time is if we're having issues of pain, dystonia and agitation tend to get a lot worse. So if that's the case, we need to investigate further, and not just in the mouth, but is there an occult, is there another site that could be creating this severe dystonia? But I think that's something that really the neurologist, the physicians, try to get a handle on that the best we can. The oral hygiene part, nobody likes going to the dentist. That's the reality. And can you make a game of it? I don't know at 9 years old, but it's a necessity, and I think there's a trust there between parents and kiddos for the most part. And we just have to get in there and do the best we can with keeping things clean. But address the dystonia. Has the therapy to treat the dystonia been maximized?
How important is it to remove the wisdom teeth? One parent says that their BPAN daughter's 23. They haven't seen any indication of problems. Every few years, the dentist does a cleaning under anesthesia with x-rays and manages any concerns. This parent is concerned how post-op wisdom teeth extraction recovery will go for her. So
wisdom teeth typically are impacted. Impacted just means that they're stuck under skin and bone, and they're not going to erupt on their own. And then you can have variations of this where they're partially impacted or even erupted. So if there is no compelling reason, there's no pain, there's no pathology, the patient's able to keep things clean, I think that we fit into that this fits into the paradigm of conservative management. The dentist is able to examine the patient. X-rays are able to be obtained, and so we've got a handle on things. The difficulty comes into play. What if you can't get X-rays, which are the majority of patients? You know, what if we can't do a complete exam, which are the majority of patients? Once again, conservative management. We do the best we can to prevent and keep things clean. We manage conservatively. The dentist and the other professionals do the best exams that they can. And if we have a compelling reason, pain, infection, swelling, then we take the next step and intervene. As far as there was a second part to the question. Was it healing or bleeding? I can't remember what the second part was, Mary Ann.
Oh boy. I've been reading so many other questions in between because there's a lot of interest here.
That's okay. Postoperatively in these patients and our patients and I'm just going to say kids because that's what's near and dear to me. The postoperative course can also be fraught with a little bit of potential issues, dry socket being the least of them. Managing postoperative bleeding, managing postoperative swelling can certainly be difficult in our patient group. And also the surgery itself can create more dystonia, potentially even a dystonic storm. So I wouldn't just say willy-nilly remove all wisdom teeth, particularly in our patient population.
That's good to know. Do any of Dr. White or Dr. McMahon, do either of you want to weigh in on this, or should we move on to the next question?
I would definitely agree with Mark on this, especially, and this is just an opinion, obviously I haven't seen this individual or anything, but by the same token, if they are able to go to the operating room and they are put to sleep and they are being examined and having radiographs taken, I would think that judgment of that dentist is what I would trust. And I would certainly agree, again, with Mark, that conservative management, if there's no evidence of infection, there's no swelling, there's no other indication for extraction, that you would be far better off. And we do this routinely in the special needs population that we see. Leave those alone. There's no reason to wake a sleeping dog.
Here's a question that makes me think, wow, I would not know what to do here. This person's son has a very loose tooth and it's been wiggly for several weeks, and the two top teeth are starting to get pretty wiggly. And the dentist said to just leave them alone, but they're concerned about aspiration. So they're wondering if they should push on having them extracted when teeth get wiggly like that, given the situation with these children. Dr. White, what do you think of that?
I mean, I can tell you from my experiences, here, when I have a patient that has, mobility can be talked about kind of in different scales of how much movement is really taking place. But if I have a tooth that's moving enough that I think it would be an aspiration risk, I do typically take it out. I don't know the specific situation. There might be a reason that they're suggesting or haven't suggested that. But I think if it's wiggly enough, sometimes it's best to avoid an aspiration risk and to have it taken out, generally speaking.
Yeah, if I could piggyback on that, Mary Ann, I don't mean to cut you off, but
No.
Once again, it's not just the wiggly teeth that we're concerned about, right? We've got other issues. And so swallowing is an issue in our patient group. Airway is a major issue, controlling secretions in airway. And so it's not like an individual that does not have PCAN, the tooth comes out in the night. Sometimes they swallow it. It's not that big of a deal. Nobody loses any sleep. But our patient population is a little bit different. In the scenario that you've given us, this is a fairly simple problem to take care of. These are front teeth, so access is not a difficulty, and this can typically be done in the office very easily. And so I would encourage the family to talk to the dentist about that. If not, get a second opinion. Go see an oral surgeon, okay? And then lastly, Nicole prompted me to think about this. You know, we need to understand that the information that we're giving is very general, right? It's not specific and treatment for each patient. So, you know, take the information for what it is, information, and apply it to your situation. But when it comes to healthcare and managing the specifics of it, your physician, neurologist, dentist all need to be in the loop on that. And sometimes it's easy to say, you know what, Dr. White said this, but you know, this is informational. The specifics, you know, we need to kind of keep the two separate.
Great advice. Yeah, I mean, these questions are specific and your answers may apply to the particular individual, but not to everybody else. And it seems to me that these parents know their children the best. This parent writes and says that her 12-year-old daughter has a Gtube. The dentist has removed all the primary teeth. The person's jaw is generally tight, so it's hard to brush inside the mouth. They're asking, should you use a molt gag to hold open sometimes? They say they try to brush at least once a day. What is necessary? And the child sees the dentist twice a year.
So the child's a dentulous, where the dentist has removed all the teeth. Is that what I heard?
That's what it's. The baby teeth, all primary teeth were removed by the dentist.
Well, and oral hygiene still is important, and running a brush, whether it's a Sonicare or a toothbrush, in my opinion, is important. But, you know, we now get into, you know, how do we help keep the mouth open in folks with dystonia, right? And we have to be really careful about that because we can cause trauma with certain types of mouth gags. My experience in patients that I've seen, you put something between their jaws and they have dystonia, they won't let go. And so it's very difficult to remove the mouth gag. And sometimes quite a bit of trauma is induced, self-inflicted, not the patient just can't open their mouth. And then depending on the mouth gag that's used, because there's many different types. And I hate that word mouth gag, right? It's, you know, a pillow or a bite block or something, but aspiration becomes a real big concern, right? You've got this little, you know, piece of plastic, and if you lose control of it, how are you going to reach back there to get it out if it's going the wrong direction? So be cautious with that. Make sure that you've got your bases covered and you're not going to cause more problems than you're going to help.
Is nitrous oxide a problem for these children at the dentist?
My understanding is it's not. It can be helpful. Okay.
And curious if anesthesia is administered in a hospital setting or somewhere else?
If anesthesia is going to be administered in our group of our NBIA disorders, my opinion would be the only place to do it is in the hospital. If a patient came to me and said, listen, you know, can I do this under sedation like we typically would my answer would be no, we're going to the hospital to do that. Mm-hmm. It's the safest way to ensure that, you know, results are not going to be detrimental.
Doctors McMahon and Dr. White, I'm getting questions about how to calm children who are just terrified of going to the dentist, just scream and cry. What can be done to calm them beforehand? One parent says that they give a little bit of Valium for relaxation, even prior to brushing teeth or any other procedures. What do you dentists think about this?
I'll defer to you, Dr. White.
So no one really likes going to the dentist. Kids don't like going to the dentist. There's certain little things that can be tried. I mean, sometimes the fear is the not understanding of what is happening and why it's happening. A dry run going to the dental office to just see the place and kind of leave. A lot of offices can be receptive to that if you call in advance and kind of explain the situation to see, how the child responds. Once there, sometimes your child will feed off of your responses. So if the parent's really elevated and worried and anxious, they do pick up on that sometimes. I'm not a pediatric dentist. I've done residencies through our pediatric program, so I can just give some examples of things that I've seen. Other than that, a pediatric dentist is going to use different terminology, different phrases to try to make it more of a fun experience for them. But fear is fear, so kind of that can only go so far. That's kind of maybe not helpful, but that's the most I can contribute to that question.
Okay. And Dr. McMahon, did you want to say anything about this?
No, I'm actually somewhat removed from the world of straight pediatric dentistry. Other than I hear the stories from my children about their children going to the dentist and some of the fear of just trying to get x-rays. And I think it's just a general thing. I personally, I think pediatric dentists are wonderful. They're very well trained in that type of a thing. But I certainly would have no, worthwhile input on that question.
Mary Ann, I think it goes back to what Dr. White and Dr. McMahon were saying earlier. Get into the dentist early so that it becomes familiar and pleasant. So you're not showing up to the pediatric dentist or the dentist in pain the first time or needing treatment the first time. Kind of ease into it, put your toe in the water. Dentist is a good guy. It's a fun place to go to. And that tends to make things a little bit easier. You commented on sedative medications like the benzodiazepines. And those can be helpful if a lot of times they're being used for managing dystonia in conjunction with other medicines, but those can be helpful if they're prescribed by a physician and taken as prescribed. My experience has been, though, that it's helpful, but sometimes more is desired. And it's a difficult issue. It's a difficult problem.
And I was thinking about the x-ray issue too. And I see there's a question here about this person has a 9-year-old with BPAN and is wondering at what age should this person, the 9-year-old, at what age should the child get x-rays and do they have to be sedated? One of you dentists want to answer that?
Again, not having recent experience in the world of pediatric dentistry, I would probably defer to Dr. White. I would say, though, that I have seen many situations in the adult special needs population where the patient has been seen every 6 months at a dentist's office. Everyone, and bless their heart for doing so, has tried their very best. And without the ability to take x-rays, things can be going on that are unbeknownst to the dentist, parents, family, patient themselves, and then only to be identified when something is very much amiss, and then the patient needs to be put to sleep. Once we get the patient to sleep, we do take the x-rays and find out there's actually quite a bit of stuff to go on that is going on. So that being the case, we would always prefer to not have to go to the operating room in general anesthetic, but if that is a possibility for that person, that would be one nice thing, a possibility to go to sleep. Or some of these, apparently, it seems like from the chats and the questions that some of these individuals are being put to sleep. If they are being put to sleep, that's a great time, obviously, to get the films. And even if there's nothing on those films, having a baseline is a very important thing. Then you know at least where you stand at one point in time, and you can go forward from there. Again, the individual specifics, as Mark was saying before, I would rely on that dentist's recommendation and follow through with them. Obviously, if there's something you have a significant concern about, the value of a second opinion is always wonderful. But again, in that age group, I would really defer to a pediatric dentist.
Yeah, I would add, the primary dentition, the baby teeth, they do typically have spacing in between those teeth, kind of when they're coming in and while the child's quite young. So if there's good spacing between the teeth, the x-rays themselves, a dentist or a pediatric dentist they might rely more on a visual exam because they can see more of the surfaces of the teeth. As we kind of change over and start getting more of our adult teeth, things get a little more crowded in the mouth, and that might be when, like maybe 6, 7, 8, when they start trying and seeing if some x-rays can take place. However, if you've been consistently seeing your dentist and they've been doing the visual exams, I would once again say defaulting to what they feel most comfortable with would be best, because they know kind of what they've been seeing and what is normal or abnormal for that patient specifically. So if it's 9 that you're worried about, I don't know if I'd be quite so worried. They're probably in the phases where they call it the ugly duckling phase. That doesn't mean ugly duckling. That just means it's because they have mixed, baby teeth, permanent teeth. Everything's kind of coming in all at one time. And you just kind of have to default to the dentist, because if there's more spacing, then the x-rays might not be quite as needed and the visual exam might suffice for now.
Thank you, Dr. White. Now I have to tell you, you're coming in loud and clear right now. So whatever you did, it worked. Here's a question. This person writes and says that there are some white spots on the front teeth that come and go and become less visible during the day. I assume it's caused by dry mouth or not enough saliva over the teeth, because my daughter sleeps with an open mouth. Is this something that they need to take care of? And if so, what should they do?
That would sound to me like simply a hydration issue, in which case that would be the mechanism by which it comes and goes. I don't know that there's anything that would need to be done about that. I would say, again, conservative management. White spots can be a precursor to a frank cavity. But again, all the other things that we've talked about with hygiene and watching sugar in the diet, et cetera, would be all, again, conservative management would be applicable here.
While I have you, Dr. McMahon, someone writes and says that their 31-year-old son with pecan is frequently in pain in the wisdom teeth area when eating or drinking. So the dentist removed one of the wisdom teeth many years ago, outpatient, no sedation. It went well, but the pecan has progressed now. And no dentist, no outpatient clinic dares to pull out his wisdom teeth, which are broken somehow. So I guess that kind of explains the pain. And the question is, I wish I could get to that easily. Let me see. The other, the person is, let's see, that's not the, oh Lord, sorry about that. Anyway, what do they need to do? The surgery need to be done to remove these? And is there anything that should be taken into account if they need to have surgery? And Mark, I think you should probably answer this one.
So this is a compelling reason to get these teeth out, right? They're painful, they're broken. The potential for these teeth to develop further problems like infection, abscess, which can compromise the airway, et cetera. So this is a situation where I would encourage this family to get in touch with an oral surgeon that has familiarity or has dealt with various neurologic diseases. But this is something that I would personally, if you had come to see me, we would go to the hospital, we'd get these wisdom teeth out. We've gone from, managing things expectantly or conservatively to now having symptoms which can lead to more significant problems. This needs to be dealt with.
Okay, good. Does anybody else have anything further on that one?
I would agree.
Okay. So I think this kind of got skipped over, but the Valium, what one person mentioned it earlier, said that they were using it for severe dystonia, so that they, could open and close the mouth easily. I just wondered if you all have any issues about that, or is that a good way to handle that?
So the benzodiazepines include Valium, lorazepam, those type of medicines, and they have multiple effects, right? They can be sedative in nature, which helps with doing dentistry, right? Takes away the anxiety. They also are muscle relaxants, and so they're frequently used in folks with dystonia to relax muscles. So in a dental setting, it can have a very positive effect on multiple fronts. I think the dentist and the physician that's prescribing the Valium need to communicate before the dentist engages in treatment to make sure that everything is on the same page and that the dentist just doesn't assume.
One person asked that anytime they repair a tooth at the dentist office, it's done under sleep anesthesia only. And is that okay? Can that affect the brain in a negative way?
Without knowing the specifics, I can't answer that question. And I'm not running from it. I just don't have the information.
Here's an interesting one that I haven't seen. Someone says that their BPAN son, age 4, has excessive drooling. Do you have any experience with atropine eye drops normally used for opening pupils, or is there something else they could do?
Dr. McMahon, Dr. White?
I don't have any experience with that myself either.
I mean, drool in our world is usually a good thing because it's preventing cavities from happening and it's in a way cleansing the mouth. So I don't know necessarily how to stop it, because when I see it, I'm usually kind of encouraged that at least it's having a cleansing effect. Now, if it's drooling to excess, I am not exactly sure what could be done for that.
So in my experience with drooling, there's several things that you need to look at and address. And I agree with Dr. White. I mean, if you're talking about oral health, it's better to have more saliva than not enough. I mean, any day of the week. But excess saliva can really inhibit day-to-day function, how people live and go about things. Certain medicines that we are prescribed for NBIA can help dry the mouth, like Artane or trihexyphenidyl. Atropine certainly can, but I would not do that willy-nilly. There are a lot of side effects that can go along with just trying to dry the mouth up. Botox is a possibility. Sometimes Botox is injected in the major salivary glands, so the parotid, the ones that make the most spit, and that can help. And so it's a multifactorial thing, but I wouldn't just use atropine to dry up the mouth but create other problems.
We've had some really great.
One other thing about that, and skin care really is important as well. If somebody is drooling excessively, a lot of times they can have skin breakdown around the mouth, and so it's important to keep things clean. It's important to keep things dry, and so the skin doesn't break down. Once the skin breaks down, it's sometimes very difficult for it to heal. So just keep that in mind as well.
That's great, Mark. In terms of, we just have a couple of minutes left, and I just wanted to say, I want to thank all these parents for their questions. They're just awesome. And there's a lot of them, and I apologize if I missed yours. I'm working 2 different panels here to see who's asking what and checking to see if anybody raised their hand, and I didn't see that. But does anybody have And I would like each of you, and Mark, maybe what you just said is your closing thought, but I would just like a closing thought from each of you based on everything you've heard, just your take home advice for these parents when it comes to oral care. And Dr. White, if you don't mind, why don't you start and just say, if we learned anything from this presentation, I hope you remember this.
Sure. I would say dietary, prevention, keeping sugars low. The best cavity is the one that doesn't exist. So if you can do whatever you can to try to limit sugar in the diet, I know it's quite a struggle in terms of brushing. To just get the toothbrush in there as much as humanly possible on as many surfaces as possible. You're doing a great job. It's a very difficult thing. We know and understand that. Get into your dentist as early as possible so that they can kind of monitor and help you know how to monitor, so that if anything does arise, it can be addressed in that way.
Excellent. Dr. McMahon, what would you say?
I think Dr. White stole most of what I was going to say. But again, just to summarize, prevention is paramount. Good hygiene as best you can. Again, you're doing everything you can. It may not be ideal. It is a compromise, but try the best you possibly can. Limit sugar in the diet. That's, again, in my experience, that is the key to minimizing decay, and it can take many different forms. For example, again, the Gatorade sounds better than Coke, but it's really not any kind of an answer. And then continual follow-up with the dentist and developing a good relationship, especially early on with a pediatric dentist, and just everybody trying the best they can.
Mark, do you have any parting wisdom for us?
I only have a minute. Yeah, here's
fast.
That's right. Here's the important thing in my mind. You have to find a team to help manage the situation. And dentistry is no different. Find a dentist that you trust, that's compassionate, that will listen to you. Put in place an oral surgeon, even though you don't need one right now. Have that contingency covered. Those are important things. Think conservatively, and if there are compelling reasons to act, then utilize the team. And you should do not only that for the dental side of things, but also the medical side of things. You should have a team in place, in my opinion, that is already keyed up and ready to go should the need arise. Be proactive.
Awesome. I want to thank you all. You guys were great. You handled a lot of information from our parents, and it was really valuable stuff. And I just thank you so much for sharing your time with us. We will take to heart your advice, and we thank you. And Mark, it's good to see you as always, and hope you all take care. And for the rest of you who are participating in the conference, please check out the merchandise, meditation, the various other things that are happening, and get to know each other. And have a great conference.
Thanks, Marianne.
I'm signing off. Thank you.
Bye now.
Bye.
Bye-bye.
Thank you all.